Hi, and welcome to the Muslim Sex Podcast. This is Dr. Sadaf Lodi, and I would love for you to leave me a review of this podcast and also to share and like it and share it with your friends, see what they think, and let me know. I would love to shout you out on social media. And also, I would love for you to follow me on Instagram at Dr. Sadaf OBGYN, as well as TikTok. I also have started a YouTube channel at Dr. Sadaf Intimacy Coach. I'd love for you to follow me on all of those channels. And most importantly, I'd love for you to become a patient. I am now accepting telehealth patients for sexual health as well as menopause health in New York and Michigan. So if you are a woman that is looking for a doctor that understands you and can actually take the time to listen to all of your concerns, reach out to me. Reach out at Dr. Sadaf at drsadaf.com. And I would love to see you as a patient. And now for the episode. I'm an American board certified OBGYN, a mom, a Muslim, and I'm talking about sex. This is the Muslim Sex Podcast. Welcome to the Muslim Sex Podcast. I'm your host, Dr. Sadaf Lodi, and this episode is everything you need to know about persistent genital arousal disorder. And before I get into it, the first thing I want to make very clear is that I'm not giving any type of medical advice. So if you are having any medical issues or you think you may have this, please speak with your healthcare provider, and definitely not giving any type of religious advice. So please speak with your neighborhood, friendly neighborhood religious leader. And so this is a Muslim Sex Podcast because I just happen to be a Muslim woman that talks about sex. And I do want to tell you again about my retreat happening September 16th through the 23rd in 2024. And I'm accepting new patients. So now let's get into the episode. And we are on episode 100.
Woohoo!
And
100. That is
I
amazing.
know. And there isn't anyone else I'd want to share this episode with except Dr. Sameena Rahman.
Absolutely.
Dr. Rahman is a superstar and gyno girl on Instagram. And she is a sexual health doctor extraordinaire. But I will let Dr. Rahman introduce herself and then we'll get started into the episode.
Hi, everyone. My name is Dr. Sameena Rahman. I'm Gyno Girl on Instagram on my YouTube station. And I'm very excited to be here with Dr. Lodi today to talk about a very important topic that doesn't get a lot of press or, details or discussion in general. So we're going to talk about persistent genital arousal disorder.
Yes. All right. So I am really interested in finding out more about this. I know that in the ISHWISH course that we had, which for those that don't know what ISHWISH is, it's the International Society for the Study of Women's Sexual Health. And they put together a fall course, which happened to coincide with my birthday.
That was
Woohoo.
fun. Yeah. We
But
still celebrated.
we did, thanks to Dr. Rahman.
Uh,
And so, anyways, they mentioned the persistent genital arousal disorder in there, and so many things that I learned that I definitely would love for our guests to learn about as well, and how it's diagnosed, what can happen, what are treatments, and what happens if you don't get diagnosis.
yeah. So, it's a disorder I think that's been identified since around I think 2001, and it's really actually I'll pull up the actual ISHWISH guideline definition because what it amounts to it's a genital pelvic dysesthesia. So dysesthesia means an abnormal sensation, and so it tends to be an abnormal intrusive feeling in your genital region, particularly related to making you feel aroused or on the verge of orgasm without any sexual stimulation or like thoughts of sex. It's very intrusive. It's a very debilitating disorder. I think maybe it has, a prevalence of around 3%, but we probably underdiagnose it and people don't come out with it because they think there's something wrong with them. Has an exceedingly high rate of suicidal ideation. Like over half of the patients that have this disorder, want to commit suicide. So trigger warning. Sorry, I should have done a trigger warning on that. But it's a very disturbing disorder for many patients. And typically the length of time is 6 months. But I'll read to where you're supposed to have these. I'm just going to read to you the exact Ishwish sort of definition of what we look at. Okay, and this was from their 2016 consensus guidelines. It's characterized by persistent or recurrent, unwanted or intrusive, distressing feelings of genital arousal on the verge of being on the orgasm, or genital pelvic dysesthesia, not associated with concomitant sexual interests, thoughts, or fantasies for a minimum of 6 months. It can be lifelong, acquired, generalized, situational, or associated with the following characteristics: limited resolution, no resolution, aggravation of symptoms, and by sexual activity, making things worse, making things better, aggravation of general symptoms by certain circumstances, sitting, driving, listening to music, general anxiety, nervousness, despair, emotional lability, catastrophization, inconsistent evidence of genital arousal on physical exam or symptoms. I mean, basically, it is a horrible disease. It is obviously, on the neuropathic pain disorders, which are increasingly hard to not only treat, but to have patients. And because of the sensitivity of the region, we always talk about the stigmas associated with what we talk about. And because so many patients are highly stigmatized by the nature of this, like, oh, why do I feel so aroused? And for whatever reason, and some of the patients that have had it their whole life, have been shamed since they were like 5 or 6 years old, where they would have these genital sensations and felt the need to masturbate. And maybe at that time it alleviated it, and now it doesn't. It is really awful. I do see, a number of patients with this disorder, but and I love to help them. It's a process. It's really there's very few times that I've ever treated anyone with this disorder that I've immediately cured them, like from the first meeting. It's one of these things where we have to go and figure out where we think the inciting factor is coming from. And, like I said, over half of the patients, have suicidal ideation. Anxiety and depression and mental distress are very much a part of this. Did it come first? Did it come after? It's hard to know, but um, most of the patients that I've dealt with have underlying anxiety disorder and become super depressed when they've been dealing with this, particularly for a long time. Some of them have history of sexual abuse or, trauma of some variety. Maybe not sexual trauma. Maybe it's trauma with their parents. Maybe it's physical trauma. Maybe it's trauma from the medical system. And so I think that it is probably a very underdiagnosed disorder. People are now, I think, able to characterize it. One of my patients recently said, who had been struggling with it for a year, you know, I didn't even know the vocabulary for this. Like, I didn't even know what to say about it. Like, if you don't have terms to use, it just felt weird. And, if she brought it up to a doctor, they'd be like, oh, I would just enjoy it and have more sex. And these patients are really on the verge of like, ending it. And you're telling them to do something that might aggravate it more because many clinicians don't know about it, right? So, you have patients that don't know, clinicians that don't know, which we know this is a big problem in sexual medicine. It's just like an understudied field and and little awareness for it. So that's why this is such an important podcast, I think.
Wow. Yeah, I mean, definitely. Well, we know that there's absolutely tons of stuff that we as clinicians do not learn about in medical school or even as OBGYNs in residency, right? Like you wouldn't have learned this if you yourself didn't take the initiative and learn more about sexual health. I didn't learn about it, until I started taking these Ishwish courses and learned about it. So this is something that definitely that's under researched, and as clinicians, we just don't hear about it. And you're right. People will say awful things like, oh, yeah, just
Oh,
go
this is
ahead and
sex,
enjoy
right?
it.
Yeah, yeah, exactly.
And they think that it's pleasurable and it's not for these individuals. So I had a question, and actually, Alan had asked the question: is it more common in women or men? Do you know that?
I think it's been more studied in men, and I don't know, the extent of, how common it is in there. I think it's around 3% of our population that we see, is at least it's statistically what we in terms of the data that we have. But it is, something that men experience as well. I don't see men in my office, so therefore I don't know as much about that aspect. Um, but I will say that, in the past 5 years, we've come a long way. I think there was something from somebody sent me a segment from like 2001 or something, where, or it was like an early 2000s, like segment where, like, crazy sex stories from some sort of, one of those programs out there. And it was like, this woman is having like 70 orgasms a day. And it was like supposed to be this thing that was like, oh, how amazing. And she was like on the verge of committing suicide. It's
Oh,
like, it was
yeah,
so awful. Like, I mean, and then I was going to do a reaction video to this, but someone sent me a video of this SNL skit where, like, they were saying this patient who had just been, diagnosed with PGAD, and it was like every minute she was talking, she was like, "I'm on the verge of an organ," and it was supposed to be, and I found it so sickening. Actually, I was watching this and I wanted just to be like, "This is so sickening. I can't believe people are making fun of such a condition." And I know it's just an appreciated, understudied, and not many people are aware of it, but I was so disturbed by watching some of this. I was like, "Oh my god," I just think about all the people out there that are really suffering, that come to my office like bawling because they've been lifelong shamed over this.
right, right, right.
And
You can see what an impact it has on individuals' lives, right? And the
mm,
fact that because I feel that our society just sexualizes everything, right? They
yeah,
think
like
that,
it's, "Oh,
oh,
it's
it
so
must
great." Yeah,
right, right, that it must be so wonderful to be going through this, whereas,
yeah,
people are really suffering when they are.
mhm.
And for the listeners and viewers out there that are thinking in their head, like, who the heck is Alan? Alan is the editor for my podcast. So just so people know. But anyway, so tell me more about this. So what are the causes of something such as the persistent genital arousal disorder?
Yeah, I think, probably in the past 5 years with all the well, I guess it was 2016, I just told you that statement came out with by Ishwish. So, past 7 years, really developed a way to kind of investigate what's happening, right? At the conference recently, Dr. Rachel Rubin joked that as, sexual medicine doctors, we're like sex detectives. But it is really true, like, especially something with PGAD where you're looking at the situation and you're trying to figure out what was the inciting agent or what are the contributing factors. And most of you know that listen to this podcast that we approach sexual conditions and dysfunction through a biopsychosocial lens, right? And so it's very similar to how we look at this condition, but in addition, we're also looking at a region based approach to evaluating this. And
Mm,
so what I mean by that is, just like any, like what we call neuropathic or nerve related pain situation, you have to figure out sort of what is the pain source, right? What is the main thing that's happening here? And so, Ishwish has come up with a region-based approach to any genital pelvic dysthesia. So that could be clitoral pain, vulvar pain, generalized pains in the genital pelvic area, and genital persistent genital arousal disorder goes along with that. And so what we have is looking at all the regions. So the first region is sort of the end organ. The end organ, what I'm referring to, is the vulva and the clitoris. Is there something happening at the level of the clitoris? We talk about, and I'm sure when Dr. Rubin came and talked about the clitoris, she talked about clitoral adhesions and these keratinized pearls, and whether or not the schmegma, that's under the clitoral hood for these patients is contributing to unwanted arousal. It could be contributing to pain. We know it could be contributing to unwanted arousal too. So that way affecting the end organ nerve endings. So that's one way to look at it. And then we look at the vulvar vestibule, which I'm sure she may have mentioned or someone else has talked about a little bit, but the vulvar vestibule, just to remind you, is the area between the inner labia minora and the hymeneal remnant, extending from this line called the Hart's line, and it goes all the way up to the urethra and down to the opening. And that vestibular tissue is sort of unique in that it's very similar to the bladder, and it has both testosterone and estrogen receptors. And so it can be very much the source of insertional pain for a lot of patients, which then can contribute to potentially arousal issues. As we know, the clitoris, as we see it, as that little body, is really the majority of the organ is under the labia minora. So that arousal tissue is there. So obviously, any injury to that area can result in overstimulation of those nerve endings. So we have that, looking at the clitoris, the labia minora, the vulvar vestibule, I think we could at some point talk about vestibulodynia and insertional pain with sex, but that can be related to both the pelvic floor muscles. It can be related to hormone deficiencies, and it can be related to inflammation and an increase in nerve density at the vestibule. So that's kind of, again, the end organ. So we call that region one. Region two is looking at the pelvic floor, and the pelvic floor, where the pudendal nerve travels through, and, the muscles that can become hypertonic. Every patient that has PGAD usually has to have some pelvic floor physical therapy. These are all patients that need a multidisciplinary approach, which includes somebody from the medical community, somebody from the physical therapy community, as well as we look at psychiatric conditions and sex therapy. So really, like, a bunch of people are helping with this patient. And so the pelvic floor therapist may do gliding of the pudendal nerve. They try to release any of those hypertonic areas. If we talk about the patients that have this with high anxiety, if you are an anxious person, you tend to be clenching the pelvic floor. That pelvic floor becomes hypertonic. Then we have, these issues around a weakened pelvic floor too. So all of that contributes to potentially the pain or this this dysesthesia or arousal feeling they have. So that's the second region. The third region, and the third and the fourth region, have to do with the spine. So if you think about your central nervous system is your brain and your spinal cord, and you have the peripheral nerves that kind of are communicated from the central nervous system. The spinal cord travels through the your backbone, right? Your vertebrae, which are like the cervical, the lumbar, the thoracic, the lumbar, and then the sacral nerves. And then all the nerves converge at the nerve to make nerve roots. At the end of that, that's called the cauda equina, which I think is Latin for horse's tail, because that's what it looks like. And so the cauda equina is region three, because those nerve roots that are the nerve roots that feed into the pelvis, right? We used to have a mnemonic. I'm sure they have so many new mnemonics, but if we went to med school, like, what, 20 years ago? So they used to have a mnemonic of S2, S3, S4 keeps the penis off the floor, because that means that those are the nerve roots that actually help for, sexual function, because they feed into the pudendal nerve, and which then eventually feeds into the nerve ending that feeds into the clitoris. So it's a whole pathway, right? And we think this is a nerve related condition. So the cauda equina is looked at very closely, and people can have abnormalities in that cauda equina area. Mainly around the area, you can get these little cysts, and they're called Tarlov cysts, which are kind of like these cysts that form in a sac that kind of compress these nerve endings, and then that might cause some excitation. They're really used to be thought of that these cysts are very like it's an incidental finding, and most spine surgeons still look at it that way. So it's been a hard sell for sexual medicine clinicians when they find these, and we think there's the causative reason to really get them to buy into that. So that's the cauda equina, and the region four is your lumbar sacral nerves. Again, the lumbar and sacral area have nerves that kind of come out of the foramina, and that's your vertebrae, and the nerves that come out of there, and they feed into the pelvis, right? So if you have something like a disc herniation, or we have these cushions between our vertebra. They're called discs, right? And so they have a portion of the disc called an annulus and a nucleus, and those areas of the disc can develop a tear, and then that can cause compression of those nerves in their own way. So annular tears, or other kind of herniations, may contribute to some of this issue as well. So that's region four. And region five is your brain, right? So the brain is involved with all the central signaling to our spinal cord and our pelvis. So we do believe that, there can be some dysregulation with your neurotransmitters. Maybe somebody's come off of SSRIs too quickly. Maybe someone's been on trazodone or other medications that are affecting, their dopamine or their norepinephrine levels. All of a sudden they're getting hyper excited. We do think that there's might be a link with patients that have, thyroid antibodies, or hyperthyroidism may be involved, with some of these patients which in turn may be affecting their dopamine and norepinephrine, which I'm sure you guys have talked about at some point how the brain is a sexual organ, and we have, things that excite us and things that inhibit us. And dopamine, norepinephrine, testosterone, oxytocin are all excitatory. So if we have too much of this, from the level of the brain, maybe it's feeding down into the pelvis and causing these intrusive feelings of arousal. So that's kind of the regional approach that we use. And again, it's like being a sex detective. You try to figure out, what may be the instigating factor. Patients with a history of trauma, sexual trauma, medical trauma, whatever kind of trauma, do develop some of these conditions sometimes as well. And so that's, sort of an understanding that we're trying to evolve. But I'm sure it sort of has to do with the plasticity of the brain and how things can affect us at the level of neurotransmitters and hormones.
That's
But
amazing.
yeah, it is. I mean, I think, from the first time I heard about PGAD, which was like maybe 2014 or 15 to now, having this understanding has been wow. Like people, they've really kind of honed in on different ways to help patients with this. So just for them to know that there is potential help is always something that they're relieved by. Like maybe I can get help from this because there's a lot of PGAD support groups like on Facebook or other places, and I have patients that'll go to them, and a lot of times they're like, oh, I want to go to the groups, but then I don't want to go to the groups because some patients are very catastrophizing, very much at the end of the rope, and maybe you're doing a little bit better or you've gotten some aggravating factors under control. And so it becomes one of these issues of like, is it going to aggravate you more or help you? But a lot of times patients will get ideas even from that, and they'll come to me and they'll say, hey, what do you think? And I was like, well, it's possible. Let's try it, or something like that. But I think that's what's kind of exciting about the field of sexual medicine is that it's so understudied, that there's so many potential therapies that we can try on patients because some of these things have just not been emphasized before. So,
Right. All right. And I think that, when there is limited research or when there's so much opportunity there, right? That's one
mhm.
way to look at it. And then there is the opportunity for more research to happen. And like we know that what President Biden just
Right.
enacted more funding for
Women's
women's
health.
right, women's health, which is long overdue, but at least it's finally coming to fruition. So I think that that's really important. So tell me, so then, once that somebody is diagnosed with this, right? And like you said, a lot of patients hesitate to come to their providers. And then when they go to their providers, they're probably dismissed
Right.
because the provider doesn't understand that this is actually a real condition and it can
Mhm.
be awful for the patient that's experiencing it, right? And so now you've diagnosed them and now you're taking a look and you've examined them. What type of therapies are available for somebody that may be suffering?
Yeah, I mean, again, I always talk to the patients about how it's a regional based approach. And I tell them that sometimes, especially the ones that have been suffering their whole life, that it might take some time for us to get there. And so we start with, each region. And if it's looks like they have clitoral adhesions, we do a lysis of clitoral adhesions. If it looks like their vestibule is inflamed and underneath that tissue is, the erogenous tissue around the urethra and the periurethral glands, we treat that based on whether or not we have to treat it with hormones or treat it with physical therapy or treat it with neuropathic medications. Like I said, they all go on physical therapy. They all have pelvic floor physical therapy. Sometimes we'll use Botox in the vagina to help release that tension, decrease the pain at the level of the muscles. Because just to reiterate that a lot of these patients do have anxiety that they've developed either from this condition or and their anxiety is contributing to this condition. And so treating the that is very crucial too at the level of region 5. We have to treat the anxiety with either the right medication or cognitive behavioral therapy or both. um, Looking at their medications are important, to see if some of them have been involved with, this disorder. And then, getting a MRI of the spine. We do that pretty readily. Sometimes it doesn't get covered. Insurance doesn't believe that sexual medicine, should get covered for anything. So
Right,
when you
right.
order an MRI, it's kind of tricky because I'm always like, "Do you have a little bit of radiating pain down your leg? Like just a little bit?" Maybe sometimes I was like, "Okay, we're writing down radiating pain down the leg," because they'll cover it for sciatica or for
Right.
lumbar radiculopathy, but they won't cover it because I tell them that it might be PGAD or something like that.
Yeah, of course not. Yes.
So our medical system is really against us in so many ways, but so we'll do that. And if it looks like, for instance, someone has an annular tear, or maybe, they do have a Tarlov cyst, that cyst could be decompressed and reduced by a spine surgeon. But again, you have to get the spine surgeon to buy into it. So I'm lucky that I share my practice with my husband, who's an interventional pain specialist. So he can do one of the injections to see if, doing a caudal block, or maybe doing, a selective nerve root block. If he does that and it helps, sometimes he'll do a sympathetic impar block, some of these blocks. And if it seems to help the patient, then, sometimes we'll get a buy in. A lot of times they have to go out of state, though, because a lot of the surgeons here will still not do that, which is unfortunate. Um, and then, we have to think about these peripheral nerves too. So sometimes we'll do those blocks, the pudendal nerve, as it comes off of the sacral area, it kind of goes into the pelvis. So that's why I talked about how the pelvic floor therapist will kind of glide or roll the pudendal nerve to see if that they can release any irritation or inflammation around that. We can do pudendal nerve blocks. Some people do develop. I had a patient with PGAD who had a hysterectomy and had a pudendal nerve injury, and one of her
Mm.
manifestations was PGAD. So once
Oh,
she
wow.
got treated for the pudendal neurop- uh, neuralgia and got some pelvic floor therapy, then she got some control over her PGAD symptoms. But obviously, that's can be difficult too, especially if the nerve is pretty damaged. And so it really depends on the degree of damage for some of these patients when it comes to their nerves and their nerve endings and their nerve roots. But a lot of my patients will go on like pregabalin or Lyrica, or some of these anti-seizure, anti-anxiety medications. They GABA receptor activators, and they kind of help with the signal from your, basically they're helping kind of diminish the signal from your brain to your spinal cord in some capacity, which may be then contributing to the signals that are going into your erogenous zones, or in your pelvis. So, and those are neuropathic pains dependent medications, trying to really, tone down that signal. So there is help. There's multiple within each region. There's multiple ideas to treat. I think region 5 is always the hardest to kind of navigate in some ways, because, you know, a lot of patients do not think they're going to get better, so their anxiety gets worse, which then makes their PGAD worse. And then a lot of patients can't figure out what their triggers are. And so it is a very difficult disease, I think, to treat, but it is very rewarding when you're able to help them in whatever capacity. If you can reduce their symptoms, eliminate their symptoms, or even when I acknowledge that this is an actual thing you're experiencing, like the tears
Right.
start flooding, right? Like, no, this is
Yeah.
real. This is not just, I mean, yeah, the brain is involved, but it's not in your head. This is not something you're
Right.
making up.
Yeah, I think somebody just validating your concerns, right, is a big deal. And
Mhm,
especially if you've been dismissed for so long from the medical community and nobody understands what's really going on.
mhm.
I'm sure they think that there's something, that they're crazy, that
Right,
that
right,
they should,
exactly.
or that they should be enjoying this, right? And
Right,
they're not. And it's
right,
just so
right,
distressing to them.
right.
Part of me also thinks that when there's so much tension in the pelvic floor, when you were talking about that, that probably contributes to vaginismus as well, I would think,
Yes,
right?
yes, they
Because
all usually have secondary vaginismus, or many of them will. Some of them will have, this really bad vestibular pain on when I do Q-tip exams, but it's like you're trying to pick which evil you're trying to treat, right? Like I'm like, "Oh, you're having a lot of pain at your vestibule." They're like, "I know, but really I wanna deal with this pressure feeling that I have." So sometimes helping to treat that will mitigate that, sometimes it won't. I think that, but I do think that, what we talked about, just acknowledging it is very powerful for them. And sometimes I feel like when I talk about some of these issues that I'm really negative toward our medical system. And I don't want to be that way. I don't think that, like, clinicians and doctors out there are actively trying to dismiss patients. But like we said, we're not getting the education that we need, right? Like, again, if you don't have the words for it, if a patient doesn't have the words for it, if a clinician doesn't have the words for it, how do we know it's an actual thing? And so it's really up to and that's why the impetus is on us to continue lifelong learning, right? We go to how many conferences a year? My husband's always like, "Why do you go to so?" And I'm like, "Medicine changes every year. Like, I'm a solo doctor. I can't be a good clinician if I'm not going to these things, you know?" Like, just like every time we go to these sexual medicine conferences, like, I'll learn 1 or 2 tidbits to take back, and the patients are like, "Oh, thanks." They really get excited when I'm going. They're like, "Oh, okay, tell us what you come back and learn." Like,
Yeah.
and I'm like,
It is exciting, right? Because there's always new research, and that's the great thing about it. When you talk about the vestibulodynia, right, the
uh-huh.
pain that happens right at that where that Hartman's line and the area between you were saying the labia minora and where the introitus is, and
Yeah.
it goes all the way up to the urethra. We know that sometimes birth control pills also
Mhm.
cause
Yep.
pain, right?
Yep.
And so they say to sometimes get off of the birth control because if
Right.
that's causing a lot of pain.
Right. A lot of
Sure.
times I'll do that as well for my patients, especially if they're so, again, that vestibulodynia that we talk about can be related to hormone deficiency. So for some patients, I think it's around 15% of patients that go on the birth control pill, especially if they go on it as teenagers. So when patients go on it all of a sudden because of their painful periods or irregular periods, they can develop these changes in the vulva area, the clitoris, through the hormonal suppression that happens with birth control, right? Like, it's and most of these patients have some sort of receptor defect, an androgen receptor defect at the vestibule. So if they're getting this medication that's lowering their testosterone, if you think about so many patients going on the birth control pill for acne, um, it can really change the way their vulva and the vagina look. Their labia can regress, the vestibule can get smaller, and I mean more like red and inflamed and angry. The clitoris shrinks in size usually, so it does in other capacities affect sexual function. And I think it's important to know that. Not that I mean, birth control pills are wonderful, and I don't want to like I feel like sometimes going to these conferences, like they're like, "Oh, birth control pills are you," but like we know that we've come such a long way with birth control pills that there's definitely like medical purposes for it, for its pregnancy. We know that, and that's important, especially when our own uterus is not under our own control these days with our government, I think. But I. But there are those patients, so I think it's just important to tell them. Like, some patients do get sexual dysfunction. So if you start noticing, you know, you know, pain at insertion, that just starts within the years of taking the birth control pill, then let us know so we can take a look. So I always preface that when I start someone on a birth control pill for the first time. But patients that are on it for acne, like, they'll choose treating their acne all day, like, usually,
Yeah,
so
yeah. I think it's so important, right? I think that with the things that you mentioned is really, I think some of the most important takeaways is just validating patients' concerns,
mhm, mhm,
letting them know that they're not crazy. And especially because we really, hand out birth control pills like they're water because they do help with so many things,
so
right?
many
Irregular
things.
menses and perimenopausal women are taking it to prevent pregnancy, but also, if they decide to take that before they start taking hormones,
Right,
there's so many benefits to it, and yet we don't really often discuss the contra the things that can happen, the side
these
effects,
side
where
effects,
you can
yes.
have that pain with insertion, you can have decreased libido, you can have so many other changes that happen because of the birth control. And so it's important to kind of go over the risks and benefits and let the patient decide whatever it
Right,
is that they
right.
think.
Because it's always joint decision making, right? We don't practice patriarchal medicine anymore, so at least
For
you and I don't. I don't know about the rest of those guys.
That's right. That's
Uh,
right. Yeah.
yeah.
So that is fantastic. So, for people that may be experiencing this, I think one of the other takeaways is that there is hope, and it's important to find a provider like Dr. Rahman who will take your concerns seriously and really go into and in depth of all the different ways that this could be happening. And, there's so many different regions. And I love how Ishwish separates it into the different regions so
Mhm.
that, you can take a look at an in-depth approach to each region and
Right,
see where you can help the patient, and
right.
that it's not, you know, be that detective that your patient needs you to be,
Right,
right?
exactly. And I think, obviously we have to give a shout out to Dr. Irwin Goldstein, the godfather of female sexual medicine. But, his I think he has been in the forefront of really trying to help a lot of these patients with PGAD because they've come to him from all over the world. So if you go to the Ishwish website, there are members on the Ishwish website who, at least will have knowledge base about this, right? It's not like you're going to be talking to someone that has no idea what you're talking about, and they should be able to get you in the right steps, getting you into the right situation to help you. So I think that is really important. And then there's a patient facing website for Ishwish called Prosela, Prosayla, and that one also has a lot of good information about some of the things that we talk about on this podcast.
Right. And I think that what's great is that, for people that are listening and watching this podcast, that they probably know so much more now
Yeah.
than their doctors
Yeah,
regarding the PGAD, right?
I know,
And
absolutely, yeah,
just
yeah,
learning from Dr. Rahman, who treats us all the time. So I think it's really important to find the appropriate healthcare provider that can give you the services that
mhm.
you need.
And again,
So
it's multidisciplinary. One person may
yeah,
not be able I mean, you can find one person that can help lead and talk to and, like, I'm always talking to psychiatrists and sex therapists, and, I have a pelvic floor therapist in my office, so, obviously, some person has to be able to bring it all together, but, you know, uh, I think, one of the best benefits from these podcasts that you can get and as not only an awareness of what other disease processes are, what might be happening to you, but also just learning how to advocate for yourself, right? I think that's what's been to me, at least when I look at social media and like YouTube and like podcasts, the one thing I see patients and it used to, I think some people get bothered by the Googling that people come, I Googled this, I actually like when patients come to me, it used to I used to maybe think in that way, but now I look at it as, they're coming to me with this information that they've gotten. Some of it is true, some of it is not. It's my job to help them discern, like what's the misinformation they're getting from, social media, what's the correct information. But either way, it's bringing about awareness to something that may or may not, help or hurt them in some capacity, right? So I think it's important to bring the discussion, like this, bringing forward a discussion to the people that are trying to help you and take care of you. So I think that's very important, and just validating, how they're feeling again is very important. But the advocacy piece is huge. I mean, if you look at the movement, even in menopause, and we talk about how menopause is having a moment, it's all the Gen Xers out there who have, they call us the latchkey generation. We were 30 when we were 13, and we're still 30 at 50 or whatever it is. But I mean, it's like, we're the ones that are now trying to take the lead on this because, we saw how the generations before us suffered, and we don't want to suffer the same way. And I think that patient advocacy has been huge in all of these movements, and that's why PGAD also actually has gotten more in the forefront, because there have been patient advocates that have come to Dr. Goldstein and Ishwish and other places that have. And I remember actually, when I first learned about it at Ishwish, they had a panel of patients actually, and one of the patients came forward with her story, and Dr. Goldstein kind of reviewed everything, and said how he helped her and everything like that. And it was really, those stories are important. I think you learn a lot from them.
absolutely, absolutely. Thank you. So, somebody listening on here is wondering and thinking like you are totally awesome. How can they be your patient? Where can they find you? So how can patients find you? And if they want to come and see you?
Oh, I'm located in downtown Chicago. I do have license in California, Illinois, and Wisconsin, Arizona, and Indiana. So I do have a couple of state
Wow,
licenses
it's a lot.
because of, especially when it comes to certain things like menopause, that we can try to evaluate patients from a distance. But yeah, that, or I'm on Instagram as Gyno Girl. I have a YouTube station, and hopefully we'll be launching a podcast at some point. So we will see how that
Awesome.
goes. But, it's a lot of work, right, Dr. Lothy? So it's like
Yes, it is, but it's worth it. And I
Mhm.
think that the information that you bring, to the table, and also that it's all research backed and evidence based, is super important because people can find information. Doesn't necessarily mean that it's right
Right.
or that it's true,
Yep.
but they will find their own information. So
Yep.
I think it's super important to have resources out there that are able to provide that credible information to patients seeking that out. So
Yeah, absolutely.
well, thank you so much,
Thank
Dr. Rahman, for joining us here today. And it's been real and really,
100. Woohoo!
yes,
I'm so
episode
proud of you.
100.
That's amazing, amazing, and your podcast has reached so many people internationally, so wow.
Thank you. Well, thank you for being a guest on here twice. And I'm sure I will have you on lots more times because you are filled with a wealth of information and such a good lecturer. So thank you so much for
Oh,
coming
thank you.
on. I
Appreciate
appreciate it.
you. Thank you as well.
It's been real and really intimate, and we are done here. So remember, this is not meant to be any type of medical advice. So if you are having any sexual health issues or any health issues, be sure to speak with your healthcare provider and find a provider that validates and values your input, and make sure that you get the treatment and care that you need. And until next time, this is the Muslim Sex Podcast. So, thank you for listening to the podcast, and make sure you leave us a review, share and like the podcast. And if you leave me a review, I'd love to shout you out on social media. So, be sure that you share it with all your friends. And thanks for listening.